Hello, I'm Mary Dunbar. I'm the senior and corresponding author of the study that we'll be discussing today on this podcast, Cerebral Palsy Characteristics in Term-Born Children with and Without Detectable Perinatal Risk Factors, a cross-sectional study. The first author is Kai Suzuki, joined by members of the Canadian Cerebral Palsy Registry, including Nafisa Hussain, Miriam Askewi, Darcy Fellings, Michael Cheval, Adam Curtin, and myself. We are supported by the University of Calgary, Hotchkiss Brain Institute, Alberta Children's Hospital Research Institute, and the lab is also supported by the Cerebral Palsy Alliance. Before I begin to discuss the findings of our paper, I'd like to go through some of the rich history that orients our findings in the much broader CP research world, and start with a disclaimer that CP is a very heterogeneous condition and that I have a specific angle from which I see it as a clinical epidemiologist and a pediatric neurologist. But there are many other perspectives, including individuals with CP, their families, other healthcare providers, advocacy organizations, and more. I have no disclosures of relevance. When we look back in time, cerebral palsy has been depicted since antiquity. Palsy comes from the Greek word for paralysis or weakness, and in the 1800s, there began to be the connection between the physical symptoms of CP with problems in the brain. And in the 1860s, William John Little described birth palsy as due to premature birth or asphyxia, which was then expanded in the 1880s by William Gowers, who defined cerebral palsy as either peripheral or cerebral due to a difficult birth. And in the 1890s, William Osler said it was due to bleeding in the brain from birth, combining findings in patients with findings in pathology. Some quick facts about cerebral palsy. It is a non-progressive motor disorder with onset before age 1 to 2. It is the most common motor disability of childhood and affects between 1 per 345 children to 1 per 1,000, depending on where you live. It's more common in boys, and the most common type is that which causes spasticity or tight muscles. About half of children with CP can walk independently, and many have epilepsy or autism. Most CP is due to events before or during birth. There are different types of cerebral palsy, which are described by the areas of the body involved and their corresponding brain injuries. In this paper, we will mention types such as unilateral or hemiplegia, affecting half the body, and quadriplegia, affecting all 4 limbs. There are also systems to quantify the impairments associated with cerebral palsy, such as the Gross Motor Functional Classification System. Cerebral palsy interventions can be at multiple stages, including prevention with improved prenatal care, improved neonatal care, especially of preterm infants, as well as therapy after the diagnosis of cerebral palsy, such as constraint therapy and many other validated therapies. There is evidence that earlier recognition and earlier diagnosis of cerebral palsy can lead to better outcomes, and thus it's important to recognize cerebral palsy risk factors. There are those that are detectable in newborns, such as being born premature or encephalopathy, and those that are only detectable later in infancy, such as parental concerns or motor milestone delay. One of the reasons that it's challenging to recognize cerebral palsy early in the absence of risk factors is because at birth, children are not using their motor systems in a very sophisticated way, and it is only with time that their divergence from the expected developmental trajectory can start to emerge. There are clear risk factors, such as hypoxic ischemic encephalopathy, which has clear diagnostic criteria and is easily detected at birth. However, only about half of children with CP have high-risk indicators such as prematurity, atypical intrauterine growth, encephalopathy, genetic abnormalities, and seizures in the newborn period. And if we go back, we can remember that all the early descriptions of cerebral palsy by all the different Williams in their very fancy chairs all related to birth trauma and birth injury. And while there is an important subset for whom that is true, today I would like to focus on expanding our understanding of when cerebral palsy can happen and how risk factors can be cumulative to increase the risk. So the question for our group was, how can we better predict CP in newborns? And that was the inspiration for a study that we conducted last year, where we developed a tool to try and predict the diagnosis of CP in term-born children. We used the Canadian Cerebral Palsy Registry, which takes advantage of universal health care available to Canada's 33 million people. It was founded in 1999 and expanded to other provinces in the early 2010s rather, and covers about half the population. In this study, we compared our Canadian CP registrants with the APRID study of healthy pregnancies to generate healthy controls. We used logistic regression to look at different risk factors which may be additive to increase the risk of cerebral palsy, and developed a calculator that would output a single number to estimate cerebral palsy risk, anywhere from below baseline population risk to very high. It was interesting to find in this study that some of the potentially modifiable risk factors in cerebral palsy may be additive to increase the risk of CP. Looking across the distribution of scores between controls and participants in the CP registry, we proposed a cutoff of 0.3 as a screening threshold, where children above that threshold should have further screening for cerebral palsy. However, if we look, there are a substantial portion of children with cerebral palsy who would fall below that threshold and be missed by this screening strategy. So the present study that we're discussing today is looking at the question of who those children are who would be missed by a newborn screening tool for children with CP. That brings us to our study, CP characteristics in term-born children with and without perinatal risk factors. In this study, we used the same population that the risk tool was based on, the Canadian CP registry. We applied that same tool to the children who had complete variables for all those characteristics, and then we specifically compared those with detectable and undetectable risk factors. When we look at this group, we can see there's an essentially bimodal distribution with a peak at about 0.3 and another at about 0.9. And our interest in this study is the group shaded in green, those children with cerebral palsy who would fall below the proposed detection threshold. So applying our tool to the 781 children in the CP registry for whom all these variables are complete, we found that 28% of them scored in the lower than 0.3 threshold range. We next looked at those who had neonatal encephalopathy or seizures, as these children would be detected at birth. We then moved these children from the undetectable risk group to detectable, resulting in a final group of 25% of the participants who did not have any neonatal risk factors based on clinical recognition and on the calculator. Looking at their clinical features, unsurprisingly, this group without detectable risk factors had less neonatal resuscitation. To our surprise, however, we found that there was not a higher rate of post-neonatal injury. We had hypothesized that perhaps the reason this group goes undetected at birth is because their injury occurs after the neonatal period. However, we did not find this to be the case. With regard to the MRI injury pattern, which will be expanded on in subsequent slides, there was less deep gray and total brain injury and more focal injury in the group with undetectable risk factors. With regard to CP pattern, we found more children with quadriplegic CP in the detectable group, and in the undetectable group, there were more children with unilateral or hemiplegic CP. The children with undetectable risk also tended to be ambulatory and use words for communication more often than children with detectable risk. So the findings that we'll go through in the next few slides are that 1/4 of children in our CP registry lack easily detectable risk factors at birth based on a risk calculator and symptoms. These children tended to have milder CP with unilateral hemiplegia, ambulatory, and able to communicate with words. Therefore, we propose that early handedness in isolation without any other risk factors is sufficient to suspect cerebral palsy, that we know that there is this important group for whom there are normal pregnancies, normal deliveries, and yet they go on to develop CP. When we look at the different patterns of MRI injury, which is based on review of the reports of MRI in the registry, we can see on the y-axis the proportion with different patterns, and the different patterns shown along the x-axis. And we can see that there's a higher proportion of children with undetectable risk factors who have focal brain injury, such as perinatal stroke. When we looked further, there is a subset of children in the registry for whom their MRIs were further evaluated specifically for perinatal stroke. And within that subset, we found that those with undetectable risk had a higher proportion of venous stroke. Given that venous perinatal stroke often represents periventricular venous infarction, which is a fetal stroke, this suggests that perhaps this subset has onset of their brain injury earlier in gestation prior to the events of delivery, which helps explain why they're not symptomatic around the time of birth, compared to the higher proportion with deep gray and total injury in those with detectable risk factors, which are patterns well established with hypoxic ischemic encephalopathy. When we look at the pattern of cerebral palsy, we can see that there's more unilateral or hemiplegic cerebral palsy in those with undetectable risk, which corresponds well to finding greater proportions with focal brain injury, such as perinatal stroke. Looking at a heat map, we can see when we look at the pattern of brain injury on MRI with the pattern of impairments, we can see that in those with undetectable risk shown in green on the left, there is a high proportion with a focal injury and hemiplegic or unilateral CP. Contrasting that, we can see in the detectable group that there is a greater heterogeneity of the types of injuries and the types of CP. So to summarize, 1/4 of children with cerebral palsy in the Canadian Cerebral Palsy Registry have no detectable risk factors based on a risk calculator and neonatal symptoms. They are more likely to have a milder CP phenotype with unilateral CP or hemiplegia, be ambulatory and able to communicate with words. We felt that an important takeaway from this is to acknowledge that there are children with CP who may not be captured by risk calculators based on perinatal risk factors. In addition, we want to support parents who find that their child has asymmetric hand use before 1 year in advocating for further investigations for cerebral palsy, even in the absence of any pregnancy or birth risk factors, as we know that this is an important minority of children with CP. Thank you so much for listening to our podcast. I'd be happy to entertain any questions or comments.